Good afternoon, and welcome to the Plasma Protein Therapeutics Association's U.S. Roundtable on IG use, where we'll provide an overview of use of immunoglobulin therapies over time. We'll detail the therapeutic benefit of these therapies for various disease states, offer the view of practicing physicians of the impact of COVID-19 on patient treatment, and discuss how policies can play a role in the optimal patient treatment with immunoglobulin therapies. My name is Stuart Langbein. I'm a partner at the healthcare group at the law firm of Hogan Lovells, and I'll be your moderator for this afternoon. Our panelists will introduce themselves to you in a minute, but first I wanted to remind everyone that this session is being recorded. In addition, as you can see from the agenda, there will be a live Q&A session. So if you have a question that you would like addressed, please use Zoom's Q&A feature to provide us with any such question. Please don't use the Zoom chat feature, but instead use the Q&A feature. So let's turn to introductions, starting with Dr. Clausen.
Hello, my name is Mike Clausen. I'm a managing director here at Adivo Associates. I'll give a quick overview of the IG market later on. And I'm an immunologist by training from UCSF.
Great. Dr. Azar?
Antoine Azar. I'm a clinical director of allergy and immunology at the Johns Hopkins University. I also direct a center for adult primary immunodeficiency disorders.
Dr. Price? Dr. Price, do you want to introduce yourself? And let's go to Dr. Mustafa.
Hi, everyone. My name is Shahzad Mustafa. I'm the Chief of Allergy Immunology, Rheumatology at Rochester Regional Health, and I'm faculty at the University of Rochester in Rochester, New York. I'm an allergist and clinical immunologist, see patients, and I'm involved in clinical research and teaching. So thanks for having me.
Great. And Dr. Wolf.
Hi, everybody. I'm Gil Wolf. I'm a neurologist, and I run the department at University of Buffalo, which is part of the SUNY system. I'm a neuromuscular neurologist, so most of the things I'll talk about are on the peripheral nervous system side, but we'll touch on maybe a few CNS disorders where immunoglobulin therapy is used.
Great. Dr. Price, I understand you may be having some video problems, but if you want to introduce yourself orally, please take a shot at it now, or we'll have you introduce yourself later. Okay. While we're resolving that, let me now provide a brief introduction of PPTA and some foundational information for our session today. The Plasma Protein Therapeutics Association, or PPTA, is a standard setting and global advocacy organization that represents plasma donation centers and manufacturers of plasma protein therapies. PPTA advocates for access to and affordability of plasma protein therapies for patients, engages in constructive dialogue with numerous regulatory agencies, and collaborates with many patient advocacy organizations. The plasma protein therapies that its member manufacturer companies produce are used to treat a variety of diseases, such as primary immunodeficiency diseases, chronic inflammatory demyelinating polyneuropathy, bleeding disorders like hemophilia, and hereditary angioedema. Plasma protein therapies often replace missing or functionally impaired proteins in individuals born with a range of genetic and often life-threatening diseases. Reliable access to plasma protein therapies allow patients to fight infections and lead healthy lives. However, patient access to these products is not unfettered. There are a number of variables that can impede patient access to these products that the patients need, such as manufacturer issues, distributor issues, government policies, physician and pharmacy protocols, and/or growing clinical need. We intend to explore these issues today. With that, let me turn it over to Dr. Clausen to discuss immunoglobulin therapy use in the United States.
Wonderful, thank you. Thanks, Stuart. I will share a quick presentation, and let's hope that the technology will work with us here. Stuart, maybe you can give me a quick hint that you can see the screen okay.
It's good.
Wonderful, thank you. At Adivo Associates, we are a strategy advisory that is focusing on rare diseases and specialty pharmaceuticals. One of them is the IG market or the immunoglobulin market. I'll give a quick overview why we're unique to position to give you an insight into the market, but then speak a little bit more about what immunoglobulins even are and what they're used for, so that we all start with the same discussion background. At Adivo, we have got over 20 years now of experience analyzing and following the immunoglobulin market. It started with supply crunch environment in 2001, and since then I've been actually following this market on a quarterly basis, and my company does so for manufacturers in that market space for more than 20 years as well. We built a audit platform, we call that, where we obtain data from hospitals and IDNs, which are integrated delivery networks, meaning conglomerates of hospitals, as well as specialty pharmacies. Those deliver usually products such as immunoglobulins to hospitals and infusion clinics, but also to home care companies, so that patients can actually use those products at home or in a infusion clinic environment. And then we obviously look also at infusion clinics. As you can see, we have got a certain sample that provides data to us, mostly volume data, so the volume of immunoglobulin products that they have purchased for each manufacturer, the patients and the number of patients treated, as well as the type of patients treated, so that we can monitor what type of conditions are treated with immunoglobulins over time. From the same institutions, we also obtain electronic medical record data, which allows us to really dive into a great deal of detail when it comes into the type of patients that require and use and utilize immunoglobulins, what indications are treated, what comorbidities those patients have, what dosing is used, and certainly also what brands are used and what type of products are used, basically. From our sample, we have to project, and we project to the entire market of the United States to assess the totality of the market, how much immunoglobulin is used in the entire market, and not only in our universe of sampled hospitals and IDNs and so forth. We use external data. We use PPTA data. The PPTA, as you probably know, manufacturers report to them on the amount of immunoglobulin that is released into the market from an ex-manufacturer perspective. We cross-check our data also with insurance claims data to see that we are not over-projecting or under-projecting on a certain indication, and in the totality of the market either. We certainly use other data such as prescription data and patient registry data and others. Overall, we're trying to project to the totality of the market. We do this on a quarterly basis and follow the market throughout its development. But first, before we go into the details of the market, I wanted to give you a quick overview of what polyvalent immunoglobulins or immunoglobulins or IG even are. If you look at the lower left-hand corner, you see a small box there with human blood components. If you think about a blood donation, plasma is the first fraction that contains immunoglobulins. This is basically the liquid part of it, so everything that doesn't have a cell in there, so no red blood cells or white blood cells. And if you look at the plasma, you can further break it down into its protein content, which makes only up 7% of it, and the rest is mostly water. In that protein proportion, again, we find 15% of it to be immunoglobulins, and the majority of other proteins that are in there are other proteins in albumin. But you can see that the efficiency of getting immunoglobulin products from blood donations to the final product has got a lot of steps involved that are called fractionation, where we get a fraction of the blood to manifest the product. The products can come in two big versions, basically, and are used in two different kinds. One is intravenously, so meaning we are infusing it into the veins of a patient. And the other form is subcutaneously, where we inject it under the skin, often with a pump, as we see here in the picture, or even manually pushed. We will talk about IVIG and SCIG a little bit more, and see the differences in its utilization over time. But as you can see, the entire industry is heavily dependent on blood donations from healthy volunteers and healthy donors. And under COVID, we all have probably witnessed that access to donation centers can be a challenge at times, and we'll talk about those developments in a minute as well. What are immunoglobulin products used for? There are two big purposes really to use immunoglobulins for. One type of patient has too little Ig basically in their body. That can be inherited, and we call those conditions frequently primary immune deficiencies. Basically, you're born with a condition where your body doesn't make enough antibodies. As you probably all know, antibodies are required to fight infections. Now, under COVID, you have seen this very often in the news, that antibodies are made against the virus, and if you make enough of it, you can defend against the virus relatively well. Patients who have got an immune deficiency cannot make enough antibody on their own. And as I said, in the case of primary immune deficiencies, that can be inherited or a genetic disorder that doesn't allow the patient's immune system to properly make enough antibody or the right type. On the other hand, you can acquire immune deficiencies. That happens sometimes when patients suffer under cancers that actually affect the immune system of a patient itself. Same thing, the patient has a disease, often a cancer disease, and the immune system is affected and cannot make more antibody than, or not enough antibody than actually needed. Sometimes even the therapy of a cancer, like lymphomas, for example, causes a secondary immune deficiency or an acquired immune deficiency. And you often have heard that probably when your friends and family members talked about chemotherapy. Frequently, chemotherapy can knock your immune system down and your body cannot make enough antibodies itself. That's called a secondary immune deficiency, and those patients need immunoglobulins to substitute actually the actions of their immune system. The other avenue is, the other type of patients are patients with autoimmune diseases. As you probably know, autoimmune diseases are diseases where your body makes antibodies against itself. So rather than fighting a pathogen, which is an intruder from the outside, here the body actually recognizes its own tissue as a foreign agent and tries to get rid of it. So your own immune system attacks your body and destroys and starts to destroy certain tissue parts. Those autoimmune diseases can also be treated with immunoglobulins in a way that we actually give a lot of immunoglobulins, because our body has got a unique feature to keep the amount of antibodies in the plasma and in the bloodstream constant. When we overload the system, we basically give the signal to purge and bring down the immunoglobulin levels as quickly as possible to a normal. With that, we automatically also purge the autoantibodies, meaning the antibodies that attack our own body. So if we give immunoglobulins from healthy donors, now we overload our system, we give the trigger, get rid of Ig overall, and by accident, we also eliminate basically the autoantibody load that attacks our own tissue. And that works very well in these autoimmune diseases that we will discuss in a minute. If you think about immunoglobulin use and the number of patients in the United States that are treated with immunoglobulins, be it IVIG or SCIG, so intravenously or subcutaneously, we're treating roughly 275,000 patients a year in the United States across a plethora of indications. We talked just about, in terms of volume on the left-hand side, you see here, 110 million grams of immunoglobulin were used in 2020 to treat patients with various disease backgrounds. On the top, you see primary immune deficiencies, the inherited ones, which I talked about. There are over 400 conditions known to benefit from immunoglobulin use. Roughly half of all PID patients are actually eligible and require IG to have a normal immune system function. So without immunoglobulins, these patients have got no treatment options at all. They need IgG to not suffer from recurring infections or other issues. On the secondary immune deficiency side, as I mentioned earlier, often caused by cancers, over 50% of the secondary immune deficiencies are actually caused by cancers overall. And there are over 200 of those causes that trigger secondary immune deficiencies. Others can be rheumatology and transplant indications, where the medication used to treat rheumatology conditions or to prepare a patient for transplant or let them actually tolerate a transplant after transplantation induces a secondary immune deficiency and requires IG in order to replenish the patient's immune system. The biggest portion of IG users nowadays are actually falling into the neurological diseases. There are over 50 automotor neuro diseases, we call it, and Dr. Wolf will talk about it a little bit later as an expert here. So there's a large number of automotor neuro diseases where the immune system attacks itself and causes actually the interaction between the neural system and the muscular system to be affected and to deteriorate. So people cannot move correctly, cannot talk correctly, cannot swallow properly. So there are all kinds of symptoms around that. There are a growing number of automotor neuro diseases where IG use is actually beneficial and seems to be beneficial, and more diagnosis goes in there to show that IG has got a very beneficial use here. And then we have got a plethora of other indications that can be, again, diseases themselves in the dermatology space. It can be a transplant itself, not the medication given for a transplant to be tolerized, but actually transplant itself that triggers a immune reaction that requires IG. Can be malnutrition even, that people who are have not enough nutrients, their immune system gets weak, and they require IG to have a healthy immune system. If you look into the breakdown a little bit, where IG is used on terms of from a reimbursement perspective and from a label perspective, you can see here that 65% of all use of IG is actually on label, meaning the IG products that are out there have a label that allows the use in PID, in certain hematology indications and neurological indications. But 35% of all uses are within the framework of medically accepted environments where a product might not necessarily have a label indication. Of those, now, if you look at that again, right now, manufacturers making a big push to get more label indications on their product to allow access to these immunoglobulin products and to ease the burden of reimbursement and also get it on a more easier prescribing path. Those are SID indications, as you can see here, myasthenia gravis, PNS, rheumatology indications, and so forth. But we still have roughly 10% of all indications, and it's a large number of indications, unfortunately, which are smaller indications where we don't have any active developments right now in the clinical trial environment to obtain label indications. The reason for that is that those indications are small in terms of patient numbers and relatively difficult to run trials in, so that manufacturers are always not encouraged to do that, and private investigators or clinicians try to collect clinical evidence through their own trials and their own publications and observations. But there's a lot of dynamic in that environment, and more and more users are actually going into the field where we know that IG therapy works from a scientific perspective, and there's a scientific rationale, but we have not a label indication yet. If you look into the market growth overall, in the last 5 years, the IG market in terms of growth almost doubled. So it's extremely quick growth. So we've got a 10% CAGR, we call that a compound annual growth rate. But if you just look into the 2015 numbers versus 2020, you see that it's almost doubled in those 5 years. And you can also see that the use of SCIG, so the subcutaneous IG products, is increasing over time and growing a little bit faster actually than the IVIG uses. And that has got to do with a population now that is on one hand aging, can be treated at home, or has got difficult venous access. Oncology patients are a good example for that. Our oncology patients get older because chemotherapy and other therapies work relatively well. So they survive their cancer and they go into multiple rounds of cancer treatment. With that, they also are, there's a population of patients now that is more prone to actually obtain a secondary immune deficiency along the way with age. So we see that part growing, and we see some of the SCIG use growing with it. We see SCIG use also growing in PID and primary immune deficiencies. Why? Because people that have that chronically from basically their date of birth rather like to be treated at home than in the clinic, and can go after their work on their day after their infusion is over later on. Overall, you can see it's a rather large market. It's a $9 billion market, the way we measure it, and that's basically based on purchases made by the hospitals and specialty pharmacies and infusion clinics overall. As I mentioned earlier, we have constant drivers here: improved diagnosis, survival rates, utilization is getting better. We're certainly getting much better in identifying autoimmune diseases, primary immune deficiencies, secondary immune deficiencies, and we certainly understand the use and the benefit of IG therapy in these fields much better than 10 years ago, I would say. That certainly drives also the utilization of it, and our clinicians will talk more about that. In the United States, from a supply perspective, we are in a good position. Most of the global IG supply is actually coming from the United States. So 60 to 70% of all plasma globally is actually collected here. However, if you go outside of the United States, you will see due to COVID, due to plasma collection issues, there are shortages that manifest themselves in other regions outside of the United States. In the United States, the manufacturers already decided to prioritize the US, and we will probably not see larger supply issues due to the COVID in the next couple of months and years. If you look into the growth of the various indications itself, you can see now primary immune deficiencies are still growing, and that is because we can identify them better. We have whole genome sequencing now to really hone in onto the genetic background of these primary immune deficiencies that are inherited and passed on. We're discovering more and more of those. Over the last 10 years, we increased the number of primary immune deficiencies that we can identify now by over 200 to 300. So our knowledge is growing quite a bit. Our diagnosis rates are growing with it. Secondary immune deficiencies, as I mentioned already, we have better therapies for oncology patients. We've got better chemotherapy, we've got immune modulators that activate the immune system to attack the cancer itself, but they are also causing, as a side effect sometimes, secondary immune deficiencies, and you can see the growth here. Autoimmune neuro diseases also growing because we're understanding them better, we can diagnose them better, and the awareness amongst the neurologists is increasing that IG therapy can actually ease the symptomology of those patients, and these patients do better and the disease doesn't progress all that much. So these patients are better off, they have less severe symptoms, and their quality of life is improving. Amongst the all others, still a market that's also a market segment is growing as we identify more patients in the very large plethora of other autoimmune diseases that are benefiting from IG. And I think that field will expand even further just because we are still learning a lot about autoimmune diseases and how they work, what the underlying pathologies are, and how immunoglobulins can potentially intervene in the disease progression overall. I hope that gave you a good overview of the market for the moment. And I'll hand it back to Stuart. I want to thank you for listening, and I hope that sets the stage for the rest of the discussion. If you have any questions, you can always reach out to me. And from what I heard, the PPTA will circulate this presentation later on. Thank you so much.
Thank you, Dr. Clausen. Just a reminder, I don't see any questions keyed up yet, so use the Q&A feature to pose a question. I'm going to get us started for the moderated discussion with some questions. But first, Dr. Price, I wanted to give you a chance to introduce yourself.
Thanks so much. Sorry, I'm in clinic actually seeing all my immune deficient adult patients. So I'm the clinical chief at Yale, and we see probably 700 or so adults with various forms of immune deficiency, primary and secondary. And we probably have 500 patients or so who are requiring infusions of IgG, either subcutaneously or IV. And we're very, very conservative. We, it's a high bar for us to start IgG because we know it's a really scarce resource, and we try to do the right thing and what's best for our patients. So thanks for having me.
Thank you for joining. So let me start with a number of questions that are going to be posed just generally, and feel free to step in each of the panelists. So the first question is, can you describe the patient populations, for example, adults, children, seniors, that you treat with immunoglobulin therapy, and how IG therapy benefits their conditions?
I'm happy to start. I primarily see patients with primary immunodeficiency as well as secondary immunodeficiency disorders, primary immunodeficiency or inborn errors of immunity. The main manifestations of these patients, like Dr. Clausen has mentioned, they don't have enough immunoglobulins, they have a weak immune system. So the main consequence is frequent, serious, recurrent infections, frequent hospitalizations. And one of the consequences of that as well is end organ damage. These are patients who can lose part of their lung function at a young age, or perhaps lose their hearing because of frequent infections. So it's infections and their complications. Treating these patients with immunoglobulin therapy, again, when the correct patients are identified and the correct therapy is identified, is certainly life-changing for these patients. It significantly reduces their infections, significantly reduces their risk of complications, the risk of end organ damage, and significantly improves their quality of life. Patients can return to almost living a normal life once they are starting on therapy.
I may add, since I'm the neurologist on the panel, as far as the age groups that I use immunoglobulin therapy for, this ranges from the youngest of children to the oldest of adults. I'll give you a couple of examples. Just a couple of weeks ago, I was helping. I'm an adult neuromuscular neurologist, but I was helping with an elementary a school child at our children's hospital who had Guillain-Barré syndrome, and she was being treated successfully with immunoglobulin therapy. Let's take another disease state like myasthenia gravis. Now, both of these disease states I've mentioned, we do not actually have an official labeling and approval for its use, but myasthenia gravis kind of has a bimodal distribution. Like many autoimmune disorders, it's quite common in younger women. And so you'll see younger women, even female teenagers with that disease state, and we do use immunoglobulin, again, off-label for that. The other part of the bimodal distribution is older men. In fact, when you're seeing the increased numbers of myasthenia gravis, it's largely being driven by older men. So again, you can see the full gamut of types of patients that we use immunoglobulin therapy for.
I'll elaborate on what Drs. Price and Azar said. In addition to primary immune deficiency, there's this big growing number of secondary immune deficiencies. So many cancers, chronic lymphocytic leukemia, Stuart mentioned lymphomas, multiple myeloma. These individuals have better and better therapies, and they're living longer, and they don't often die of their cancer. They actually die of infection. And we know a lot of the therapies that we treat them with knock down bad antibodies, but with that sometimes go good antibodies too. And that's what puts these people at risk for increased infection. So this is actually the patient I see most often with my hematology oncology colleagues, a combined multidisciplinary approach to treat their cancer, but then to also kind of monitor, survey for infectious complications, because that's a big cause of morbidity and mortality. When these individuals are sick and they're having febrile, pneumonia, they can't get their chemo. So it all goes hand in hand. So working as a multidisciplinary team, we really do believe that we're hoping, hopefully improving the outcomes of these pretty common cancers. And Dr. Wolf mentioned too, there are limited studies and indications for some of these uses that we think. So this is where I think these numbers are growing, and we have so much more opportunity to learn and hopefully improve patient care in the clinic. I'm a clinician. I think everyone on this panel see patients 4 days a week. So it's had a huge impact, Dr. Azar mentioned, on quality of life. These people are frequently sick, and then really a small percentage, significant percentage do very well on immune globulin. So that's another indication that, I see a lot of in our office.
I just wanted to add and build to that, the treatments for cancer are also sometimes being used for autoimmune disease, particularly the B-cell depleting therapies like rituximab. And I work very closely with rheumatologists because as we're immune suppressing a lot of these autoimmune patients, their immune deficiency are kind of brought out. So there are a subset of patients who get these immune suppressing medications and they develop really serious infections. They're in the hospital with terrible infections, and it turns out that they have immune problems. And sometimes it's not clear if it was originally primary or secondary from the medication, but that's the situation they're in. And they require IgG to even be able to get through their autoimmune treatments and further therapies. I feel the patients we're seeing today are so much more complex than they were, even 10, 15, 20 years ago. And as we're manipulating the immune system, turning it up, turning it down, you need IVIG as a tool to get the right balance and to keep people healthy and able to tolerate their treatments.
Great, thank you all for those perspectives. The next question, again, for all of the panelists. The use of IG therapy has increased over time, and several possible reasons have been given for this, such as increases in diagnosis, especially early diagnosis, life expectancy for IG users, individualized dosing, expanded/additional indications, and better awareness among physicians. As a treating physician, to what do you attribute this increase in the use of IG therapy? And I think some may have already touched on this, but let's explore that a little further.
I'll jump in real quick. I think awareness, you can't take care of something if you're not thinking about it. So I think there is an increased awareness of immunodeficiency, both primary and secondary. And Dr. Price mentioned a lot of our therapies for malignancy cancers, blood cancers, and rheumatologic conditions deplete B cells, deplete our cells that make antibodies. And the indications for things like rituximab and other B cell depleting therapies are increasing. So every yin has a yang. Those are great therapies for some of these conditions, but they have consequences. Other therapies for malignancy, CAR T cell therapy, this is a pretty young group. It didn't even exist when I was in training. And now, it's expanding indications by the month for CAR T cell therapy, which also leaves people with significant hypogammaglobulinemia. So again, more potential for uses for immune globulin. So I think awareness is a big one, and then expanding therapeutics that leave people with antibody deficiencies, I think, is a big part of it.
I'll jump in there again from the neurology perspective. And I hate to be critical of the community of neurologists that I'm part of, but I'm going to be. So look, peripheral neuropathies, these are diseases that affect our peripheral nerves. They're very common. Diabetes represents half of all peripheral neuropathies, just to give you that background, but there's hundreds of other causes. There's a certain disease that Stuart mentioned, chronic inflammatory demyelinating polyradiculoneuropathy. I know that's a mouthful. We call it CIDP for short. We never use the whole terminology, but that's the full name for it. CIDP we know is treatable. It's an immune-mediated neuropathy. But there is literature on this from Johns Hopkins and from my colleagues at Minnesota and from my colleagues out in Cedars-Sinai. It shows that the overall CIDP population that's labeled with that disease, half of the patients really don't have it. But you can bet that those patients who don't have it are getting immunoglobulin therapy. I don't want to get through all the reasons of why they're getting it. They get subjective responses, they feel somewhat better, but they really are not improving from a functional standpoint. They should not be getting immunoglobulin therapy, but it's responsible for a lot of this growth. There's other reasons for that growth as well. In the peripheral neuropathy framework, I can point to a study that was just done, that was just published in the last week or two from colleagues, neuropathy colleagues in the Great Dutch Group in the Netherlands. They did a study looking at IVIG versus placebo in painful small fiber neuropathy because IVIG is being used in small fiber neuropathy. Empirically, the trial was negative. IVIG had no better response than placebo in reducing pain from small fiber neuropathy. So I'll leave it there, but there is inappropriate use in my field with immunoglobulin therapy.
I can jump in and just following up on Dr. Wolf, there's certainly some inappropriate use of IG therapy in certain situations. And if we have time, we're happy to talk about this in more detail, maybe less in our area than in neurology. But yes, like what Dr. Klassen mentioned in the presentation and the other panelists, there's significant increase in the use of IG therapy. If you look at the data in the last several years, there's been a marked increase in the number of patients diagnosed and treated with primary immunodeficiency disorders. There's been a marked increase in the number of inborn errors of immunity as well. Like Dr. Klassen mentioned, more than 400 disorders now have been identified, and they definitely go up by the year. And a lot of these do require immunoglobulin therapy. There's an increased recognition, increased diagnosis. We're not at all where we want to be, but this is on the primary immunodeficiency end. And like my colleagues mentioned, there's a lot of situations with secondary immunodeficiency where whether cancer therapy or transplant or autoimmune disease, where we have a significant improvement in therapy for these disorders, but as a consequence, we have weakening of the immune system and hypogammaglobulinemia. And Dr. Klassen also mentioned in the presentation some other situations or where IG therapy is used, where it's not an FDA-approved usage, but from people's experience and from small case series and reports, people know that that it can be beneficial for a number of conditions, and I believe that these are also increasing, and that's another reason for the increase in IG therapy use. So there's many reasons for that, and I do anticipate that this will continue to increase in the future in terms of demand for IG therapy.
And just to add maybe to Dr. Wolf's comment there, I mean, we're all aware of the misdiagnosis or overdiagnosis of CIDP. Just to give a balancing view there, it became a little bit of an indication that has been accepted by insurance companies to be reimbursed. So we find in our data, at least, that sometimes patients are actually diagnosed with something, the different automotor neuro disease, but their reimbursement will not allow them access to product. Hence, under the CIDP codes, they unfortunately get reimbursed. And that's also one growing factor why CIDP as indication seems to grow, that basically misdiagnosed for billing purposes, which underlines the fact that they might have another condition that cannot be treated because the patient doesn't have access to the proper insurance environment.
Great. So let me move to the next question, and now we'll think a little bit forward and thinking about the future. How do you see the clinical need for IG evolving in the future, and how might that affect your practice? In addition, as you're thinking about that, in your area of expertise, have you observed an increase in demand for IG therapy for which the clinical evidence isn't strong? In addition to what we were just talking about, are there other conditions where you're seeing, what Dr. Wolf was describing? So, let's talk a little bit about, where this is going in the future, in addition to following up on perhaps some other conditions like Dr. Wolf was describing.
I'm happy to start. So, yeah, that Dr. Wolf was just mentioning these conditions. So overall, I feel that I'm certain that the use and the need of IG therapy will continue to increase in the future the same way it has been over the data that you showed, this marked increase over the past several years for many of the reasons we talked about. Now, regarding the use of IG therapy in places where it's not warranted, yes, we do see this. And we unfortunately see this sometimes, and there's many times where I recommend for my patients to discontinue IG therapy that they've been receiving for a while. I don't think this is something that's extremely common, but I say it's unfortunate because it's pulling away from people whose life depends on regular use of IG therapy, and it may be being used in not only in conditions but also in doses that are higher or than is warranted. So there may be some balance here. Some of it has to do, as you mentioned, Dr. Clausen, with sometimes insurance approval and the payers and what they approve and they don't.
Yeah, I'll just reiterate, I think the use will be increasing. And I don't want to paint a completely a black picture here, a negative picture here. IVIG is critical for our managing of several different immune-mediated neuromuscular conditions, Guillain-Barré syndrome. I'll add myasthenia gravis with a little bit of a caveat in there. CIDP, it is primary therapy. The first neurological disease that got a label, an indication for IVIG was CIDP, and that's now 15 years ago. They help us eliminate the need or reduce the need of things like corticosteroids, which we all know have terrible adverse events. But the increasing need, let me give you an example, the immune-mediated, and they were mentioned on one of the slides, encephalitides. Many of them are linked to actual antibodies to different receptors that are involved with glutamate, which is an excitatory neurotransmitter. IVIG is commonly tried in this growing number of encephalitides, of encephalitis, horrendous disease states. They don't always respond to IVIG, but many do. Those are increasingly recognized. That's going to drive further use of immunoglobulin in the future as well.
I wanted to follow up on that, and thank you for that, Dr. Wolf, because I was thinking of asking this group, are there other conditions where breaking out your crystal ball a little bit, where you think IVIG use might increase, where maybe it isn't being used as much now? I think, Dr. Wolf, you gave a great example of that. I wonder if there are any others that people can think of.
This may be my training bias, but with my interest in secondary immune deficiency, I think it's going to increase in the space of hematology, oncology, and rheumatology. I think it's becoming increasingly recognized, increasingly talked about. I think there are, more individuals seeing immunologists along with their rheumatologists or oncologists. So I think it's going to increase in that space. And we often say IVIG, but in the setting of replacement therapy, subcutaneous is a great option too, obviously, and I think we'll touch upon that. But just immune globulin replacement, Dr. Azar is 100% right. There's no way it doesn't increase, and I think the increase will be appropriate as well, just as our knowledge base improves.
To build on your comments again in the hematology oncology space, there's a lot of immunotherapy use now with the checkpoint inhibitors in cancer. And with that, there are developments of these immune-related adverse events that kind of mimic these autoimmune conditions. And like Dr. Wolf and everybody is saying, you want to try and avoid steroids or at least long-term steroid use. And so even in these IRAEs, as they're known, some people are also using IgG as an anti-inflammatory along with other biologics. And so those are other uses for IgG as well.
Great.
I will reinforce what Dr. Price had mentioned. I mean, I totally agree that secondary immunodeficiency is definitely on the rise and indications will go up. But Dr. Price had mentioned that, but to take the example of patients with vasculitis, for example, I mean, it's a horrible disease that involves many organs. People can suddenly lose their sight, for example, because of vasculitis. It's a really horrible disease. If not diagnosed very early and treated very aggressively, patients have significant morbidity and they die. But anyway, the only FDA approved maintenance therapy for ANCA-positive vasculitis is rituximab. That it controls the vasculitis well, but the number one cause of mortality in these patients is not their vasculitis, it is actually infections. So now we're treating a disease, managing it well, but then the main consequence is patients are dying from severe immunodeficiency from infections. So there may be a lot of roles there for immunoglobulin therapy. It's been used, we've published on that, but it's something that requires more systematic studies.
Great. Let me turn to a couple of questions that tie into access. First is to ask whether any of your patients have experienced issues accessing their immune globulin therapies before or during the COVID-19 pandemic. And if so, how did you keep people stable when you were experiencing, or if you are still experiencing, some inability to get patients the immune globulin therapies they need?
I would just like to start because I haven't really had patients have exacerbated access issues during COVID, but I can just tell you at a baseline, we never have enough. Our institution never has enough. We're always asked to drop the dose to, below ideal body weight. Can you give this person less? We are essentially kind of rationing what we have and trying to divvy it up among all the people who need it. And that's without COVID. So then you add COVID and this, what's great is that I think everybody now knows about antibodies and convalescent plasma and everything. So at least it's in the forefront, but we've never had enough. And I think all of us here have worked in various ways to try and improve plasma collection. Anything that can be done needs to be done. There's not enough. And I'm really waiting for the question about insurance and coverage. That'll really get me worked up.
I'll be sure that gets in the mix, but let me let others weigh in as well on this.
Yeah, I can talk a little bit about COVID. Luckily, the majority of our patients with immunodeficiency are on subcutaneous immunoglobulins. And that's, therefore, the COVID pandemic has not had a huge impact on these patients. That we've been able to supply and maintain most of our patients on immunoglobulins. They did not, they are high risk for infection. They didn't want to come to the hospital and infusion center. So most of them are treated at home by self-infusions. But I agree with Dr. Price. There's always issues with do we have enough? And there are always issues with that come up every few years. Pre-COVID, we had a problem where we had shortage at some point, and some patients were delayed. And just to reiterate how important immunoglobulin therapy is for these patients, you know, IVIG is given every 4 weeks or every 3 weeks. Sometimes missing one infusion or being about a couple of weeks late for one infusion will result in some of these patients, ending up in the hospital with pneumonia or sepsis. So it's critical for these patients to be able to get their infusions on time. So yes, unfortunately, this happens every once in a while. You asked about how were we able to deal with it. I mean, at some point, just to give you an example, we had to, patients who were in subcutaneous immunoglobulins and it wasn't shortage. Let's say they were receiving 15 grams or so. We had to go and look to find vials of 1 gram each and have 15 individual vials to be able to add them up to have enough for the patient. The brief thing I will mention as well, patients, all immunoglobulins products may not be interchangeable. So if a patient is doing well on one product and tolerating it well, doesn't mean that you can just immediately switch to something else that's more available. That's not always something that's easily doable. Some patients don't tolerate certain products but do tolerate the others. So that moving from one product to the other may not be as just a simple thing to do.
Just to provide a perspective over time, so our department runs the infusion clinic for all the university practices. It's in neurology here. And so I've been here now in 9.5 years in my leadership position. And so I can recall in those 9.5 years, 2 periods of shortages of product, which really impacted patient care. And as Dr. Azar mentioned, Dr. Price mentioned, this is not good. From their perspective, infection risks and so forth. From our perspective, increasing weakness, motor disability, falls, not good. Those were shortages that persisted for several weeks where we really had to delay therapy. Fortunately, since the pandemic, we haven't had that compounded on these other challenges that we're dealing with COVID-19. But it's always of potential concern.
Next question is about switching, and Dr. Clausen spoke of sub-Q IG, and so I wanted to see if you would talk about your patients switching to receive IG treatment at home, which I would presume might involve sub-Q rather than IV. And if patients have switched, can you talk about the benefits of switching? Are there benefits in improved compliance? Are there benefits in relation to reducing the risk of infection? And so just want to open that topic for discussion.
Here, I'll jump in here. Like Dr. Azar said, as an immunologist taking care of immune deficiency, where we're replacing antibodies, unlike Dr. Wolf, who's kind of doing it for other reasons potentially, we use predominantly exclusively subcutaneous rather than IV. There's generally far less side effects with using subcutaneous administration. Patients tolerate it much better. They have patient autonomy. You can do it at home. Patients can do it at their own leisure. They can be trained and typically in 2 to 3 nursing sessions, so they can do it, at their convenience. So you have safety and you have, patient preference. And when there's survey studies on where patients want to do their immune globulin and what they want to use, 80% will say subcutaneous. And not only that, but I'd rather do it at home on my own. So we primarily use subcutaneous, and I think those are the 2 biggest factors of tolerability and then patient autonomy in a world of shared decision making, where we kind of want to lay appropriate choices in the hands of our patients and they decide. That's often the choice. So, I mean, that is actually, Dr. Price mentioned insurance coverage. One of the biggest frustrations I have is sometimes there's coverage for an IV formulation, but not the sub-Q, or, vice versa, just kind of haphazard coverage, which really boxes you into choices that may not be optimal for patient care. And I don't want to derail the conversation with that right now, but the supply between IV and sub-Q is not always the same. Sometimes there's shortages in IV, but not sub-Q or vice versa, and then certainly insurance coverage. But for replacement, there's a lot of literature to say, efficacy, protection from infection is similar, but tolerability and patient autonomy may be superior with subcutaneous.
And Dr. Mustafa, if I can just follow up on that, for the patients who are getting subcutaneous IG, is that are they predominantly using it at home, or is there some that they're coming to you and receiving it, in your practice?
Yeah, I think this may vary region to region, practice. Ours are almost exclusively self-administering at home. We've tracked how many nursing sessions it takes. On average, it's about 3 sessions for our patients who want to do this. Now, don't get me wrong, some patients prefer IV. We have fantastic clinical staff. They go sit in the chair, they're well taken care of. But, there's risk factors, obviously, with that, healthcare, utilization, exposure, all that stuff. But the vast majority of our patients do self-administer subcutaneous at home by choice.
Okay. The next question I'll ask, I think Dr. Wolf touched on this, and maybe we'll move off it pretty quickly, but I wanted to give, just put it to all the panelists. And that question is, do you prescribe IG therapy for conditions other than those approved by the FDA? Dr. Wolf, you talked about Guillain-Barré syndrome and myasthenia gravis, but there may be others. And if you do prescribe the therapy for conditions other than those approved by the FDA, how do you decide that IG may have the therapeutic benefit for the patient, and what evidence guides your decision on whether to prescribe for that use?
Sure. So no, we definitely use it outside the labeled indications, which for neurology are still just 2, CIDP and multifocal motor neuropathy. They are brand specific indications, although CIDP has at least 3 different products, actually 4 when you consider sub-Q and IVIG forms, 4 different products labeled for it at this point. MMN is really just one company. That's multifocal motor neuropathy, another mouthful, not as bad as CIDP perhaps, but we call that MMN for short. It's a pure motor neuropathy that can masquerade as ALS. It's definitely something that you want to pick up because it is treatable and can cause prominent weakness, especially in younger to middle-aged men. But those are the labeled indications. Outside that, I've already mentioned myasthenia gravis. I've mentioned Guillain-Barré. We have placebo-controlled studies and studies comparing IVIG to plasma exchange in the acute stages of both of those diseases. There is very, very good evidence that IVIG is as effective as plasma exchange. It's easier to deliver. It's more accessible at many medical centers that do not have plasma exchange or plasmapheresis facilities and staff. So it's commonly used in those unlabeled disease states. There are plenty of other disease states, though, where it's tried. I'll give you a few examples. Stiff person syndrome, which actually is more of a central nervous system disorder, although it ends up in neuromuscular practices because of its manifestations. It's used there. It's used sometimes in multiple sclerosis. Now, I think there's 20 drugs now approved from MS. IVIG data in MS is not the strongest, but it is occasionally used, especially in home-based therapies for multiple sclerosis at times. Lambert-Eaton myasthenic syndrome, similar to myasthenia gravis, but instead of being a postsynaptic disorder, this is a presynaptic disorder at the neuromuscular junction. It's quite rare, much rarer than myasthenia gravis. Half of the cases, by the way, are associated with small cell carcinoma of the lung in smokers. Anyway, there is series of data that IVIG is effective in Lambert-Eaton, and which is not, since it's so similar in many ways to myasthenia gravis, it's not a huge leap of faith to think that IVIG may work in Lambert-Eaton, which again is an antibody-mediated disorder like myasthenia gravis, but on the presynaptic terminal. You had dermatomyositis listed under rheumatology. Dermatomyositis is a form of inflammatory myopathy. We use IVIG at times in various inflammatory myopathies and myositis. I'll add another one, necrotizing myositis, that's caused often by statins, not always, but often. Certain forms of necrotizing myopathies respond very, very well to IVIG, and we have serological markers for that, like signal recognition particle. I'll stop there. I already mentioned the encephalitides as well. So yes, those are all those are all unlabeled disease states.
Other moderators want to address the unlabeled uses question?
I just think it's important to mention that there are evidence-based reasons to use immune globulin that do not all have a label. I mean, that's what Dr. Wolf just went through, and that's in our space too. So there's good scientific evidence, they just haven't hit a label yet. I mean, you know, it kind of tells you when the labels are brand specific for the same type of therapy. You know, sometimes the evidence is there, but the label's not. So I think, yeah, I think when you're taking care of individuals, it's important to take care of the person in front of you.
So are you, in those situations, are you looking at the evidence before deciding on the unlabeled use?
Certainly, I'd hope we'd all practice evidence-based medicine. And, you know, I really, I don't trust myself to have many opinions, so I follow the evidence. But in states, again, secondary immune deficiency is not on label in the US, but it is in Europe. You know, there is good evidence to say that it improves outcomes in that scenario. So absolutely, if there's good scientific support to do it, I think it is appropriate. And that's where we have some shortcomings and difficulties with labels and insurance coverage and things like that.
Well, and let me seize on that, because I'll introduce our discussion into insurance by this question. So this will be a baby insurance question, which is, you know, in thinking about where you have prescribed off-label uses, have you and your patients experienced any payer problems with respect to those unlabeled uses and receiving the immune globulin therapies?
I think the simple answer is yes. And I loved what Dr. Price said, a very high bar to prescribe this stuff. We don't prescribe it. It is a very high bar. It's a limited resource. It can be very efficacious and a life changer, like Dr. Azar said, but it is a high bar. We don't prescribe this stuff unless we think it's really scientifically indicated. And of course, we still have difficulties with reimbursement, copay plans. Thankfully, I work in a system where my clinical staff does all the heavy lifting. But we have dedicated individuals, a team of dedicated individuals in a practice of 9 providers that work with prior authorizations and things like that. So it is a never-ending challenge. At the best of times, our supply is right on the fringe of what we need, and our coverage is always a challenge. So yeah, it is a challenge. There are ways around it. It doesn't always work out costs. There are individuals, I think, where there is significant cost prohibitive issues. And I think that would be for patient advocacy when, again, we're working with good scientific backing on appropriate, you know, treatment. There's a lot of work to be done in that space, in my opinion.
Okay. I do have another insurance question, but I think Dr. Price had to step out for a minute. So I'm going to hold that one because I want to really get her energy on the insurance question. So let me ask something that's a little more patient focused. So in your practice, have you seen a demonstrable change in the quality of life of your patients using IG? And if so, could you describe those major changes that you see in patients?
Yeah, absolutely. It's a huge change for patients. Again, like all my colleagues here are mentioning, when the bar is set high for those who need immunoglobulin therapy, for those patients who need it, it's a huge change in their quality of life. You're talking about somebody in the immunodeficiency arena who's constantly sick, off work, off school, going into a vicious cycle of illness after illness. They get an infection. It takes a very long time to recover. As soon as they recover, they're sick again. A variety of different infections, whether respiratory tract or skin or infections require hospitalizations. So immunoglobulin therapy for these patients leads to a tremendous improvement in their quality of life. They could, and there's a lot of data on this, patients can go back to live a normal life as long as they receive regular treatment. So it's a huge change.
Yeah, I'll just mention both in the trials of, say, diseases like CIDP and in regular practice, because we administer some quality of life and ADL measures. We do that at every patient visit. you will see improvements based on IG therapy introduction. So yes, you do see these improvements.
Okay, I think, again, I'm going to hold that insurance question for Dr. Price. So maybe what we'll move is, I know we've got a number of questions teed up in the Q&A function. Again, if you want to add something, audience members, if you want to add another question, please do so through the Q&A function on Zoom rather than the chat function. And so we'll start with those questions. The first is recombinant IG is being developed to replace plasma-derived IG. And the question is, when can we expect the first clinical trial to start for recombinant IG?
Yeah, I can chime in here probably because we've been following the market obviously a little bit on that part. So there's one company right now that has got a phase 1 trial for COVID indication actually of a polyvalent hyperimmune product that is recombinant based and it's just going through the safety data assessment. I have not seen that particular company or any other going into the recombinant IG environment for PAD or SIDs. So I don't think that any of those trials have started. There are preclinical IND enabling experiments done right now. So I think we will see those moving forward in a certain amount of time now. But yeah, it's still very, very early on the safety side.
Okay. So the next question is, so the questioner notes that the questioner participated in a webinar a few weeks ago presented by the Immunoglobulin Nursing Society. And one of the immunologists who presented said Takeda is publishing a study any day now that found protective neutralizing SARS-CoV-2 antibodies in immunoglobulin, far more than plasma manufacturers had predicted back in February. Octapharma published a similar study a couple of weeks ago. The question for the panelists is, can you update us on whether patients have protection from COVID through their IG therapy, noting this could be a game changer for patients who do not mount a response to the vaccine or have adverse reactions to vaccines?
I can chime in with my thoughts here. Doctors Wolf or Azar may know a lot more about this than me, but from the time someone donates blood, they collect plasma, there's a significant delay until that immune globulin gets to the patient, 6, 9, 12 months. So, you would have to think about when did most donors have COVID antibodies at the time of donation, which, in the United States potentially, was this last summer or a little bit before, maybe with the vaccination campaign and natural infection. So if you go, 9 months from this last summer, I would expect there to be significant antibodies in commercial immune globulin formulations come next year. Certainly antibodies should be trickling in with my patients who are on replacement, who we talk about this with consistently. I would not expect them to have clinically meaningful levels of antibodies at this point in time. And again, I'd love to hear Dr. Azar or Dr. Wolf, their thoughts. So, we certainly continue to practice risk mitigation, the importance of vaccination, even in immune deficient individuals, because there is potentially some ability to, immune deficiency is not one size fits all. There's lots of differences, and some may respond to vaccination versus not. So I think that's coming. Eventually, immune globulin replacement will have antibodies for COVID-19. Certainly, I don't think we're maybe quite there in a broad clinical sense.
I agree. Sorry, Dr. Wolf.
No, go ahead. Go.
No, I agree with that. The question mentioned if can we consider IG therapy at this point protective against COVID, and my short answer is no. I agree with Dr. Mustafa, unless there's some new data that comes up that I'm not aware of, but no. I would not consider this protective. Totally agree with Dr. Mustafa. We have to rely on other things. We have to rely on the vaccinations. The question mentioned if somebody does not mount antibodies to vaccines, there's a monoclonal antibody that can be used for people who are at high risk. We've used it for our patients with immunodeficiency who got COVID in the acute setting. I would not rely on immunoglobulins. I would not consider them protective, at least for the time being.
Yeah, I'll only add, and I'm not an immunologist, nor am I an internist, but I think it's high hopes to think that IVIG is going to be protective, as the others said. And I'll just add, and I can be corrected by my more medical-oriented colleagues on the panel, I think they've largely given up. It's not the same thing. I do realize this, but convalescent plasma, I think, has been largely removed from the therapeutic armamentarium that they're giving to active COVID patients. So, you know, it's not exactly the same thing as a manufactured IVIG product, but anyway, I'll just make that point.
Yeah, I can just probably chime in here as the immunologist, one of them. So yeah, the concept of convalescent plasma is not a new concept. It's an old concept. It's been 40, 60 years old. And unfortunately, in other diseases, has not worked all that well either. So there's not necessarily an expectation that it will work all that much better under COVID now. Certainly, if you manufacture it, if you enrich the donor pool for COVID-exposed patients or from COVID-exposed patients, to enrich the amount of anti-COVID antibodies in that product. And but to Dr. Mustafa's point, the clinical data that we have seen so far, it might work to a certain degree and maybe 20% of all patients, and we don't really know what those patients are. So we have a very limited pool of supply, first of all, to get to that plasma or this IG, and then giving it to the right patients is going to be really difficult. Maybe it's something for patients who cannot tolerate the vaccine at all or don't have a reaction to the vaccine. Maybe we can use it there, but use up then again a very, very scarce resource. For treating, we have seen, again, maybe it works in some patients that are really badly off and improve a little bit, but it's only 20% of the patients roughly. And we don't know really why and where and how. So we would give it somewhat blindly to probably the worst cases where we don't have any other options anymore.
So another COVID-related question. How good is the evidence for using IVIG to prevent COVID cytokine storm?
Not good. I'm not sure of any good studies that say that's effective therapy that should be widely used. I'm fairly up on COVID therapies, but they keep changing by the hour, by the day. So I may be missing something, but I don't think that's in our therapeutic arsenal when someone is PCR positive for COVID or hospitalized or being treated. There's other approaches that are getting more and more scientific support, but I don't think that's.
Great, thanks.
Yeah, I believe by the time you detect or try to prevent the cytokine storm, it's almost too late. The patient has it already. So I don't think that we have good data on that at all because we cannot intervene early enough.
Okay. This next question is for Dr. Wolf. Do you see any of your MS patients being treated with Ocrevus? Sorry if I misspoke that. Developing hypogammaglobulinemia after a year or so? And if so, are you treating them with IG? Hopefully I didn't butcher that so much that you understand the question.
I got the question. I don't take care of multiple sclerosis patients. I wish I have 5 faculty who do. I know they use Ocrevus a lot. It's an infused drug. It's a B-cell depleting therapy like rituximab, but you only need, well, rituximab you don't have to give very often either. They get it every 6 months. It's been one of these game changer drugs in MS. But as far as the side effects that was mentioned, I really don't know. I wish I had one of them. I could run down the hallway and see if one of them is there, but I don't know.
Okay.
I'll chime in. I don't know as much as Dr. Wolf about the neurology stuff, but B-cell depleting therapies, part of the side effects comes from the disease state. For example, the same B-cell depleting therapy in a blood cancer is more likely to have clinically meaningful immune problems than in a rheumatology and potentially neurology as well. So we have seen patients in our office with presenting with significant infections, and what I'm thinking of, significant pneumonia leading to sepsis, multiple hospitalizations after starting Ocrevus, who, there was other therapeutic options, so we stopped the medication. But that may be an appropriate role for immune globulin replacement in that setting. But I think these complications with some of these therapies depend on the disease you're treating, because the disease itself also has endogenous immune defects. And I think neurology might be less than blood cancers from my experience.
Yeah, I would briefly add, I've seen a lot of these patients as well with significant hypogam. We have, of course, much more data on rituximab. It's an older drug, but like Dr. Mustafa, Dr. Wolf said, hypogam can definitely occur. Patients can get severely hypogammaglobulinemic with an IgG levels in the 200s or so and get a lot of infections. One thing to remember, this is from rituximab, it takes an average after rituximab is discontinued, it takes an average maybe of about 9 to 12 months for immunoglobulins to recover. However, there's been patients reported, patient that we have seen who takes 10 years after rituximab, they still have not recovered and they're still very hypogammaglobulinemic. And this might have to do that at baseline, the patients may have had some underlying uncharacterized immunodeficiency to start with. But the hypogam after the B-cell depleting agents, most patients do well, but in some patients can be very prolonged.
Yeah, I think from a literature perspective, you can see that ocrelizumab, which is the antibody behind it, in comparison to rituximab, has got a slightly higher B-cell depleting and secondary immune deficiency inducing potency there. So, I would presume that in the clinic it will manifest similarly over time, that we find patients that develop SIDs because of it.
And one more quick comment on just general comment for some reason, this is not in the US guidelines, but in the European guidelines, when they start B-cell depleting therapy for, say, lupus or vasculitis or autoimmune disease, they recommend checking immunoglobulins prior to starting therapy and prior to every course of therapy, say every 6 months or so, and rechecking immunoglobulins whenever patients develop clinical infections in order, again, to identify these hypogam patients early enough and decide how to manage them. I don't believe in the US we have such guidelines, at least from the rheumatology perspective, but it's for years in Europe, they do a much better job, I think, at recommending checking immunoglobulins.
So Dr. Price, I have two questions for you, which are somewhat similar. First, you mentioned earlier that your institution is very conservative about starting a patient on IG. So one question is, why is your institution take that conservative approach? And then the second question for you is, you mentioned restricting IG use because you never have enough. If you had an unlimited supply, how would that change your therapeutic approach? So two sort of related questions for you.
Sure. I guess I'll start with the second question first. I don't know how much it would change it, except that, we would just want to be able to do what we recommend, a certain dose at a certain time interval. When we're short, we have to either stretch to, more weeks in between or decrease the dose. So it wouldn't necessarily change how we do it. But then, the first question is, why are we so conservative and restrictive? And I think that's multifold. One, we want to do, so yes, it's expensive. Yes, it's in limited supply, but we have to do what's right and what the evidence shows. And so we try to really, really stay by the book. I think that we have to be able to uphold standards, and that's why we do it. In our practice, we often will, if people have frequent infections, trial people on prophylactic antibiotic regimens, and if that works, then even if they would have qualified for IgG infusions, that might be the best. It is quite individualized and tailored, and we're trying to be very, very thoughtful because there are several implications for every decision you make.
Great. So in the interest of time, I'm going to pose one more question open to all the panelists for a very quick response. And that question is, what can be done to increase on-label use for some of the conditions with small patient populations where clinical trials are difficult to execute?
I can briefly say that clinical trials can be carefully planned and done even in really rare diseases. I mean, sometimes you do a clinical trial on 20 patients only, where you do, if it's well set up and well done, it's a randomized clinical trial. Some drugs have gotten FDA approval based on really a small population, depending. So this can be done, but of course it needs the funding, it needs the support, it needs the availability of IG products to be able to do such trials. But these can be done.
I'll just briefly mention the autoimmune encephalitides that we talked about a little while ago. I remember a few years ago, some leaders in the field saying there would never be a randomized placebo-controlled, well, it's not really, a randomized controlled trial in that group of disorders. One is being done right now. Now, intravenous gamma globulin is not the investigational agent in that entity, but they have organized a trial in a very acute disorder that is not all that common, and we'll see how it goes. So there are ways to do it, as Dr. Azar just mentioned.
Well, I think we're at our time. I want to conclude by thanking all of the speakers for sharing their time and expertise with us today. And likewise, the audience, thank you for the time, attention, and some great questions. As a reminder, this roundtable will be available on the PPTA website, and a summary of today's event also will be available at the PPTA website. I also want to thank the PPTA staff for their hard work in putting this all together. And I just wish to say thank you to everyone again, and have a great afternoon.
Thanks, everyone.
Thank you so much.
Thank you.
Bye.
Thank you very much.